Okay, we're in the home stretch here for today. Great first day of the conference. Hopefully everyone's gotten some caffeine and maybe some popcorn. Good call on the popcorn, by the way. So let's get started. So I'm Amir Javedan. I'm the Chief Operating Officer for Well Health, and I also oversee our Technology Solutions Group. And thank you for Infoway for a great conference and the opportunity here to spend a couple quick minutes talking about what we do at Well before introducing our keynote. So at Well Health, our mission has always been about digitizing and tech-enabling healthcare providers, really reducing their burden and equipping them to provide more effective care to their patients. And we do this through the two main segments of our business. Firstly, we own and operate the largest network of medical clinics across Canada, with over 180 clinics and growing quickly. This is a multidisciplinary clinic network spanning primary care, allied health, diagnostics, specialty care, and mental health. The technology we use to power our own clinics comes from our second main business segment, which is our Technology Solutions Group. This division has a broad set of digital health solutions, which we use in our own clinics, as well as offer to clinics and doctors outside of our network. This division includes our EMR group, which is the third largest EMR in Canada, our billing and back office group, which provides and offloads the administrative overhead around provider billing management and other back office needs such as IT and cybersecurity. And our third division, which is our digital apps group. This group includes technologies from OceanMD, which is Canada's most widely used online booking solution, with nearly 5,000 doctors and over 900 clinics using it today, as well as other patient engagement modules such as secure messaging, automated reminders, and a powerful forms engine. OceanMD is also the country's most broadly used e-referral program platform, and it powers the e-referral program now for BC, Ontario, New Brunswick, and Nova Scotia. And they are now delivering more than 1.5 million e-referrals and growing quickly. Our digital apps group also consists of our AI solutions. This includes ambient scribe and physician workflow automation, clinical decision support, which leverages AI to synthesize and summarize unstructured EMR records to identify rare, chronic, and complex diseases, and our inbox automation, which automates the triage and prioritization of inbound documents. We also have a number of other solutions relevant for public sector organizations, including digital front door and patient mobile app solutions, which we got to see highlighted today with the VeriSource team, an Uberized virtual care platform, as well as cybersecurity monitoring for health systems and hospitals. In aggregate, our portfolio of technology solutions is used in some way by 1 in every 3 providers in the country. Before introducing our esteemed keynote speaker, I'd like to leave you with one of my favorite quotes from Winston Churchill, which actually came to mind before I realized the UK connection with Luke. And the quote is this: "You make a living by what you get, but you make a life by what you give." And at Well Health, we're honored and proud to be giving and serving healthcare providers who are the bedrock of our healthcare system. With that, I'm pleased to be introducing Luke Readman, who is the Director of Digital Transformation for NHS England. Luke has an incredible career as a strategic and innovative digital health leader with extensive experience leading change at system and institutional levels across the full spectrum of healthcare. He has a strong track record in service transformation, exploiting digital, data, and technology adoption at scale. Luke began his career as a practicing radiographer before moving into leadership roles driving digital transformation. We are fortunate to have Luke join us today from across the pond. Thank you, Luke, for making the trip out. In particular, because everything sounds smarter and better with a smooth English accent, of course. But in all seriousness, Luke is really a thought leader in all things interoperability, and we're lucky to have him here today. He's the joint chair for an interoperability-focused organization called Interopen, and beyond that, he's been pivotal in the success of OneLondon, a groundbreaking initiative uniting London's health and care systems to create a truly interoperable, patient-centered healthcare system, which he will be digging into with us today. With that, please welcome me in joining Luke Readman.
Well, hello everyone. Are you good? Yeah, you're good. It's been a good day, hasn't it? I've enjoyed today. It's the first time I've been to a conference like this in Canada, but it feels like home. Isn't that strange? Or maybe we should just expect that. So my name's Luke, and I'm from London. And for those of you that know any English TV, it feels like an episode of Surprise, Surprise, that statement, doesn't it? I'm going to tell you a little bit about the journey over the last 5 years and where we think we're going around sharing data to drive improvement. I don't like to use the term interoperability because it's a sort of technical description of something and it changes. So what we thought the problem around interoperability was a few years ago, the problem is slightly different today. And so we've got to bear in mind that whatever we do in this world, it's in the context in which we operate, and the context has got many different elements. And I'm from Manchester originally, so when I get stressed or when I have too much beer, I go into my Manc accent. So if I go into my Manc accent today, you can remind me of that. So here I am on my father's knee in 1963. And you see my father, my dad, is looking a bit shocked, isn't he? You know, he is looking a bit shocked, isn't he? And my mum's looking very cheeky, looking over to him. See all my brothers and sisters there. And the family story is, he's looking a bit shocked because mum has said, and there's another one on the way. So you never quite know what's in the data, do you? You just really don't until you have a look. And then the other reason for putting this up is because with my siblings, we're baby boomers, born, in the years after the Second World War. There are 4 new hips amongst us, okay? Several other medicines keeping us going, and we're living longer. We're living longer because healthcare is keeping us living longer, and lifestyle driven by that healthcare is keeping us living longer. And in part, the growth in baby boomers is driving an increase in healthcare. That increase in healthcare is not going to start to level off in most Western countries until about 2040. So the current payment systems, the current delivery systems, we cannot continue to use going forward. What are we going to do differently? How are we going to use data to help do things differently? And the third reason I put this photo up is because it's all about people. Growing up in a large family, one thing you had to do was get on. Because if you didn't get on, your brother would eat your tea before you got home. So, you had to get on and you had to work through your problems. And that's a characteristic of what we got to do today. We've heard about lots of problems, but together I firmly believe we can solve them. So, a few years ago in London, I was working in East London, one of the 5 integrated care systems in London. I'll tell you a little bit more about those in a moment. And we started developing a concept of a learning health system. And I like this children's book by Kobe Amanda, What Do You Do With an Idea? Now, the book doesn't tell you what the idea is, but it's how a child has an idea and is frustrated to start, but then acceptance starts to build. And at the end of it, the idea becomes pervasive. And I like it because, particularly of the works of Victor Zhao and Charles Readman. And Victor Zhao says a learning health system makes clinical data research grade. And we all know that when we do research studies, we often collect the data specially. When we come to implement the new medicine or the research and evaluate that sort of 3rd or 4th stage trial, we don't quite get the same results as the research because the data's a bit noisier. And then the second one, Charles Readman, is really good. Every consenting patient's characteristics are available immediately. Their experience is available immediately to learn. Improvement is continuous. This happens routinely and efficiently. It's part of a culture. But what is a culture? Interesting question. And I'm going to put it to you that really what we're talking about is data. I want you to think about every other industry that's transformed itself, that's got rid of its back office, and it's got data, it's got digital systems doing stuff, and the public doing it themselves. In travel, to come here, I just went on the phone and booked my airlines. You know, it all seamlessly, nobody else involved. You think of every industry, banking. So how do we get rid of the back office, move it to the front office? Well, if you haven't got good data, you're not going to be able to do that. And I put it to you, we've got to give a focus onto how we make that data available across all our experiences, linked, so we can improve care at the point of care and make better decision making, which I guess is what Connected Care is about. To support improvement at scale, because we always want to improve, and we should always want to improve. And if we can't improve, we won't get more efficient, we won't get more productive, we won't put different patient pathways in, and to put patients in control. And it's a very deliberate word, control. We are sort of challenging existing cultural precepts, which is the doctor is in control or the system is in control, and we're shifting that. And I think that's a challenge to us all. So, the real challenge, though, is about leadership. All of you, and me and my colleagues back in London and England, we've got to sometimes make quite brave decisions, because there are always choices that we have to make. What resources we have varies. Who our leaders are vary. You know, our political leaders, certainly in the health service in England, I think we've had 6 health secretaries in 4 years or something, you know. So leadership's really important, and you've got to keep moving it forward. But what we must never, ever forget is why we're here. And this is Bramwen. Bramwen had a cancer diagnosis, but it was late. A year to 18 months late. Several institutions in London repeated tests, lost stuff. Stories you've told today, and I've heard on panels, exactly the same. So we must never, ever forget that. Whatever our particular professional biases are, this is what it's about. So London is a sort of biggish, complexish system. There's around 10 million population registered with GPs. On a Monday morning, there's about 13.5 million in London now, with travellers, with people coming into work. We have 5 integrated care systems, and in England there are 42 integrated care systems. Populations of around 2 million, 1.5, 2 million. In London they're a bit bigger, 2.5 million. 35 trusts, 1,400 general practices, 32 local authorities, hospices, care homes, about 40 universities. And I've got 24 different EPRs. If you look at primary care, if you look at acute hospitals, look at mental health, community systems. Now, some of those are the same, so I've got several versions of Epic, but you all know that when you put in the same system in a different hospital, it's configured differently. And so the universal plug-and-play stuff doesn't work quite as easily as you might always expect, does it? One of the characteristics of London, though, which is helpful, is that in any one of those integrated care systems, if you only look inwards, you miss about 20 to 30% of the care that your registered patients receive, because they receive it in places outside of the geography of that integrated care system. So the boundaries that we put around our organisations are artificial. And the only way to think about this is in terms of the patient's journeys, the public's journeys, and what happens to them. Now in London, we've got 2 main systems that sit within all the endpoints. And by endpoints, I mean a system in a hospital, a system in a GP practice, a system in a community service. If I think of the middleware that sits between all of that, okay, We've got Cerner, now Oracle's HIE system, and we've got a better open EHR platform. We've got lots of standards, you'll see in the bottom half of this. And so when we talk about FHIR, open EHR, or DMND, or ICD-11, actually, in SNOMED, we're moving to OMOP, all of this has got to work together somehow. This complex environment has got to work together, and you've got to try and make sense of it. So there is this question, why do we need OneLondon? And it was clear a few years ago, about 2015, 16, that some local places in London had started sharing data point to point, a hospital and their local GP practices, let's say. Different mechanisms were in use, but they were missing an awful lot of the journey and an awful lot of the care. And if you imagine you're a junior doctor in A&E and a patient comes in, or the emergency room, a third of the time you might get something and a third of the time you might not. Well, you download an app on your phone, you try it twice. If you're lucky, if it's not going to work most of the time, you stop using it. And it's a bit like that. You need stuff that's reliable and works well. So now in London, we have a single approach to the way we share data at the point of care, to view at the point of care. 2 clicks, 10 to 15, 20 seconds, and you get a very good summary across all those settings. Okay, acute care, specialist care, primary care, mental health. Most of social care, but remember we've got 32 different social care systems in London, so there's about 2/3 of them at the moment are in there. And we've got 5 programmes now that you can see below here. So the London Care Record, which is what that's called, something called a Universal Care Plan, I'll talk a little bit about that in a moment. We're just about to go live next week with the first phase of what we call an e-mental health programme. I don't know about in Canada, but in England, patients with mental health problems receive a bad deal compared to the rest of the system. They tend to be underfunded, and that applies to the digital and data world as well. And particularly patients who are severely ill, where the police may be called, or a social worker may be called, or an ambulance may be called as the first line, they rattle around the system with lots of paperwork. So connecting all of that up is an important programme now. And I hope that means we can get mental health patients and investment in that onto a proper trajectory going forward. We've got this other work around 999 transfers of care. And you all know, if you've worked in ED or you've seen it on the telly, an ambulance is dispatched and it's on the way to your hospital, or you get a phone call to say there's a patient coming in who's had a cardiac arrest or a trauma or whatever, and you write down what's happening. Well, we're going to transfer what happens in the ambulance, and we've done this now in two initial evaluation sites, live, and pre-register it in the hospital system in ED, so that it's available before the ambulance with the patient arrives. And it will be structured data. And then we've got this other data strategy, and I'll talk a bit more about that at the end. There's other stuff going on, but these are the main programs now that we have live across London. So the London Care Record connects the whole of London. There are several health integration systems, and we've extended that outside of North London, in particular into the home counties, and we're going around London. So we'll get all the inflows will be covered in the next 2 years, I would think. The QR codes will give you links to our website with lots of resources, should you want them. The use of that has been amazing. There's this point I said earlier about it's got to be useful. It's got to be usable, and it's got to be used. So the doubling time of use of that record, views per month, is about 10 or 11 months. And in September, it was just over 2 million views. 100,000 different clinical professionals using it every month. We've had it evaluated, and you've touched a bit on evaluation today, but not as strongly as I would like. I would say to you, for every programme that you commission, you must commission evaluation independently at the same time. And you must use that evaluation to change what you're doing going forward. This evaluation by Queen's University in Belfast has demonstrated that we save time. Very simple metric, we save time. People chasing stuff that we've heard lots of today. We heard it in the last panel. About 1.3 million minutes per month and growing. So far, and we connected this a bit early, April 2020 we first connected it, 3 to 6 months earlier than the plan, but because of the pandemic we wanted to get a wiggle on. We've probably saved the equivalent of 92, 93 million, maybe a bit more now. So we've easily outstripped in time the investment we've made in it. Now that's not cashable, but it's a pretty powerful statement when it's backed up by independent evidence. And we call each view a moment of care. And you can see there are lots of stories like, it helps me quickly find out which hospital or ward and how many times they've been admitted. I was able to give him the best support and treatment, freed up an ambulance. Lots and lots of, and we publicise these stories. I don't know if you've ever heard of the taxi test. I've tried this a few times, we haven't quite got there yet. So you go into your local station and you jump in a taxi outside your local station. And as you're chatting to the taxi driver, you say, have you heard about the London Care Record? What is it, So I've not had much success, but I'm sort of hoping. And then we've got this other platform which is linked to the Universal Care Plan. Now, there was a precursor to this in London, something called Coordinate My Care, which is an end-of-life planning tool, allowed patients with their clinical professionals, usually their palliative care physicians, to agree where they wanted to die, the conditions of their death, what their DNA status was. It wasn't adopted very well. It was very bespoke, very technical and efficient. And so we 3 years ago, purchased an open EHR platform deliberately for this, which we've integrated well. So we exchange data into our primary care systems. They get flags, they get some codes. If they enter those flags or codes locally, they come into the system. So that's the first time I would think we're properly moving a bit of data around. The shared record is a view on demand. So this has been very effective. And the other thing we've got in England, which has helped us enormously, is the app for the NHS in England, which I have on my phone here. So if you've got now, from January this year, an end-of-life plan in London, you can view that on your NHS app. And your carer, or husband or wife or whatever, can view it as well, or parent for a child or so on. From January, February, you will be able to request changes to that care plan, to your healthcare team, through the NHS app. So, in a quiet sort of way, we're starting to allow patients to enter their own data, because we're also expanding the app. Before summer this year, there are about 20,000 patients with sickle cell disease in England. I know they're a particular ethnic minority with very bad experiences. We've got about 9,000 or 10,000 of them in London, and about 7,500 to 8,000 of them now have a plan. And they have the same ability to view it, and will have the same ability to make changes. And we're extending this so that any patient could put in a set of about me characteristics. Anyone. That will be available in the next few months. So you could, if I'm in hospital, my dog needs care. Those sorts of questions which people worry about. Now, this isn't really about tech, I'm going to tell you. This is about people, right? So for the end of life plans, it's not the digital community that make that work, really. I mean, we do stuff, right? But it's the palliative care physicians and their colleagues. They lead that work. They're in the forefront of it. I was speaking to them last week, and they want some changes, and we'll work with them on those changes. For sickle cell, it's the specialist haematologists who lead that work. They will speak to their own patients about this, and they will bring them on. So, and it's one of the characteristics that we can't do this generally and expect it to work. We've got to target this. Because if we want to change culture, so that this becomes normal for anyone to be able to use the app to record stuff, it must be used. If it's not used, it's not really worth it, and the patients will stop putting the stuff in. To change culture, we've got to make sure that the first use cases are really very well used, and then this becomes normal. That's what's important. Now, I've got some data from September. This week, by Friday, I'll have the data for October about this universal care plan. The two vertical columns on the left-hand side, you can see it's doubled its use. Tells you sort of which area in London that the different colours are in the last year. And the numbers, 7%, 40%. This is where these platforms linking and working together is really important. The shared records had great success. Most of the access to the universal care plan, 40% of it is from the shared record professionally. So if we didn't have a way of making it easy to get to, it wouldn't be used. That makes it very easy to get to. The others are bespoke links into various systems. It's a bit like saying, if I sell you an insurance policy, well, it's the insurance company that gets the money, but I'm going to get 10% of the income. Well, if I got 10% of the income for that, you know, we'd make loads of money. We don't, but it's that sort of principle. And we should be thinking about those sorts of principles when we're trying to get these adopted and used. But the biggest thing is about public trust, okay? We start on the left-hand side in this fragmented system. We want to be on the right-hand side, but there's a legitimacy gap. So I don't know if you remember the Facebook Cambridge Analytica story that sort of Facebook was selling details to Cambridge Analytica, and they were using that for sort of political and pseudo-political purposes. It was a big scandal, certainly in the UK. And when we asked the public about this, they sort of lost, you know, they were very, very skeptical about these big companies. Yet, nevertheless, they signed up to them. I mean, when you ask them about health data, they have even stricter controls requirements, okay? And they expect us to police those with them. They don't expect them to be left alone. So we have run 4 large-scale public deliberations. And I'd like to just call out, while I'm here with you, the work of Michael Burgess from British Columbia. He's a world expert in this sort of deliberative action. He came over to us in London and spent 4 days with us, helping us through our first large-scale deliberation, very valuable. So we went through various stages. It took us a year to get to a 4-day deliberation over 2 weekends. And we finished it early March or late February 2020, just before lockdown. And we had 100 people in a room and we had a whole series of health professionals speaking to them about our problems with data and why we could or couldn't use it. We wanted them to speak to us about their problems with data and why they didn't want us to use it or did. And they then formed a set of recommendations. And these were the public's recommendations across London. And the public we selected were geographically distributed across London. They were distributed by income. They were distributed as data skeptics or data enthusiasts. You know, there were ability, disability. There were lots and lots of work went into this to make sure it was a good selection. But if you add up the first 2 categories there, you know, over 95% said you must use data at the point of care by joining it up and making it available. And the second one, over 95%, strongly agreed that you must use our data anonymized for research and improvement. So the public view was strongly in favour. Now, one of the problems we have had is that when we go to some clinicians or some GP practices, they say, well, I am the data custodian for my patients. And I'm taking the view that I'm not going to share data because I think there are risks. We have not had an argument or a political way of saying, actually, your public want you to do it. So you've got, how as a leader do you create these big arguments where people will listen to you and then you can bring them along with you? Now you've got to build trust as well at the same time. You can't do it like sort of as a blunderbuss, but it's really important. It's been really important to us, this. And we've had 3 further deliberations. First on health data, second on opt-outs of use, and that is still the most confusing one. Who has what opt-outs in what circumstances? The legal position is confusing. The interpretation of the legal position varies, and there are different lobby groups. And then, as we develop what we're calling a secure data environment in London, we've had further discussion, and out of that we've now got a clinical advisory group of about 100 people, and twice a year we meet with them and discuss with them, and they advise us on what to do. So what of data then, if I keep going on about data? Well, I like these 2 charts. The one on the left is a coxcomb chart. So that was drawn by Florence Nightingale during the Crimean War, and the distance from the centre, the radius, gives the scale, and you can see it records deaths from different causes. I sort of prefer the one on the right, though. This is John Snow, the Broad Street problem. This is Soho in London. Now, John Snow was a physician who was called in to have a look at why people were getting ill, seriously ill, and dying. And actually, his training, his apprenticeship, was from some coal mines in the northeast of England, Newcastle. And if you read up about him, you'll see he probably had seen this disease before, and probably had already thought that there was a relationship to water, because there are all sorts of other theories that it was a miasma in the air or something else. And you can see the black lines. He just plotted on a map where the deaths or the illness was recording, and the nearest pump was the pump in Broad Street. And depending what you read, he either locked the pump or took the handle off. And people stopped getting ill and stopped dying. Now, I prefer the one on the right, because that's a learning health system. It gets the insight, but it implements the action to make a difference. Now, implementing action, and there was a lady on the panel here who was speaking about the 17 years half-life to implement, and that's taken from the American Medical Yearbook 2020. There's a very good article with 10 different things like flu vaccination, cardiac angioplasty. I think it's 17 years is the mean time to 50% use of new, widely accepted techniques. What use of data then? Because you've got to know, is it direct care or is it for something else? So this is a precursor. We're just going to switch off the system that produced this data because we're moving to another platform. This chart represents 3 of the 5 integrated care systems in London. So it's about 6 million people's experience of GP visits or GP consultations in this chart, going back to 2017 monthly. And you can see the dip every 12 months is Christmas and New Year. You can see a winter peak if you look at sort of October, November, December, January over that dip. The green is face-to-face. The reddish at the bottom is telephone, and the blue is total. And you can see the effect of the pandemic. A drop-off in face-to-face, which slowly started to pick up. So that takes you, I think, up to December 2020. But a big increase in telephone. In fact, there's another line in there, which is video calls. It's only a small line, though. Despite the pressure on video, it was telephone that was used in the main. Now, we produced this. I produced this in the first week of January 21, when there was lots of pressure from our primary care GP colleagues about the workload they were under, and the health minister, Matt Hancock, did not believe them. So I said, I can produce a chart. So we produced a chart, and we gave it to somebody called Nikki Kinani, who was the GP primary care lead working in Department of Health. She took this chart to the health minister. and got £150 million out of him on the basis of this chart to go back into primary care. So what's your purpose for the data, right? So it's really important just to think about it a little bit. Why are you going to put data together? But it worked. It's a famous chart. In my world, it's famous. And then we've done some other things. We have pump-primed Pathfinder projects. So put some money into it for asthma and air pollution. You know, we have people who die because of exacerbation of asthma because of air pollution in London. Cancer and diagnostic pathways. Blood pressure and cardiovascular prevention and preschool immunisation rates. Problems with all of these areas. So we've put some money into them about 3 years ago on the basis that the improvement using data at scale could be rolled out to 2 of the integrated care systems and ideally 3. Now, 3 of these have just going to 3, one of them staying in 2. So it's working, it's not there yet. So you've sort of got to, as you're doing things, you've got to find other techniques to drive what you're doing. You've got to use the trains while you're building a line. You've got to fly the aeroplane while you replace the engine. All of those things apply. And we have some more. We're putting some more of this pump priming money into new projects around asthma, hard to diagnose cancers, and complications from diabetes. And I just want to give you one other sequence of problems. So in 2021, when we started using the AstraZeneca vaccine in England, a small number of people started getting very ill, more women than men, and they were getting blood clots in their brain. And we had a problem that there were no coordinated national data feeds to give detailed, near real-time information. So this is different to the use cases, because we were relying on surveillance. So it was haematologists who were saying, well, these people are coming in. They set themselves up twice daily calls around the country, not quite everywhere, to report this. So we put some work in to see, could we do it using data? And we then did a phase 2. On the phase 1, we sort of ended up with this question, if you follow the arrow across about 10 million population. This wasn't just London, it wasn't the whole of London, but it was some other places across England. Show me all the COVID vaccine patients, 5 to 30 days after vaccination, who attended the ED presenting with any type of thrombosis and features of low platelets, raised FTPs, and a platelet factor PF4 antibodies. It was the PF4 antibodies that were the real key characteristic. So we had to take data from 3 different places: our vaccination system, our primary care system, and our A&E and hospital systems. We had to link it at patient level. We then had to determine what patients that was, and we had to feed it back to the clinicians in the hospital who admitted those patients. And then the second phase, because we then said, well, can we scale this up? Can we get to a bigger population? And we're exploring variation acute hospital admissions. And the second part of that was for those with acute myocardial infarction. It's probably still the single biggest group of people who attend A&E is those with chest pain. So, for the phase 1 results, it was actually very difficult to say how many had a possible vaccine complication. If you look at worldwide data now, it's about 1 in 800,000. And the incidence was just impossible, but we could detect some. It was a different number to those detected by the surveillance. What was the agreement? Difficult. You couldn't use it in research, needed further work, and because then that vaccine stopped using and that problem went away, we didn't have the opportunity. And then what we did do, though, was we took between 1 and 3 months out of the timeline to find these people. Okay? So it's significant, that. So what is the problem you're trying to solve? So another reason why I don't like to use the term interoperability, because it doesn't describe the problem. The second 2, avoidable admissions, you can see these admitted ambulatory care conditions, low risk of chest pain on the right-hand side and so on. The top 5 of those, which were 50% of all admitted patients, look at that line and look at the way the points are distributed. Each one of those lines is a different hospital admitting unit, emergency department. There's a 300% difference in somebody with a low-risk condition being admitted or not admitted, depending on where you go to. So that's an insight. So the next question is, let's dig into that and find out why. Because if we can improve the effectiveness to the best quartile, then maybe we'll make a difference to the way our services are delivered. And then the second one was for those with potential myocardial infarctions, high sensitivity troponin test. If there is a negative result, a very low risk of those patients being discharged home, having a subsequent heart attack. But look at the total width of the line, the colours are the high, low, medium risk. At the bottom, 70% discharged. At the top, Site A, only about 25-30% discharged. Again, why is there that variation? So think about the purpose, think about the problem, think about what you're doing. And that came up with a whole set of recommendations, and that has fed into something called the Sudlow Review, which I haven't got in here, which was published last week. So I'd encourage you to look up the Sudlow Review, a really important piece of work about how we curate data feeds going forward at national and subnational level. So what we're really trying to do is drive proactive care and to support planning and to support research and development. Actionable insights mean we have better population health outcomes. Screening is a big piece of work. Okay, how do we identify people and do stuff earlier? How do we identify the subclinical cases so we start to think about their care and their lifestyle before they become clinically symptomatic? And so what we're now doing in London, and we're making good progress, is we're building our London data service. And this is jointly funded by some national money from research and development and by local NHS in London monies. We're building our London data service fed by all our systems that have data, including the shared environments I talked about earlier, for direct care planning and for R&D. And we apply something called the 6 safes because we've agreed with our publics that we'll apply the 6 safes. And for each of the use cases that we put forward across the 5 integrated care systems, we'll consult with our publics, and there'll be a governance process which says, are you happy about this? What are your conditions? And then we'll report back the findings to them. So that open, transparent approach with our publics in London is maintained and becomes a really important driving force to align our professional and service. Without that, I think we'd have more difficulty, and it's hard enough, right? I'm not trying to say it's easy because none of this is perfect. So by April, we will have 5 systems worth of primary care, all our core hospital data sets from acute, mental health, community in there, available for these purposes. And our biggest direct care use is going to be to put more effort into prevention, cardiovascular disease, and supporting local integrated services to identify patients at risk. So we have this question about, okay, so we're building a set of platforms across London. Well, aren't we just doing the same thing again? You know, what does technology do, right? So we have a good idea, we sell it, we sell pejoratively, and then we add bits on. And after a few years, it becomes unmanageable, so we reinvent it. So we see it, don't we, in our phones in our pocket. We get new software updates every year. All our apps seem to get updates every day, It's amazing. This will become unmanageable unless we think very carefully about what our version 2 is. And our contract expiry for most of this is about 2 to 3 years. So we're thinking about this now because we want good user experience, whether that's a clinician or a patient. We've got to have workflow, alerts, communication data. So all this middleware, you could say it's a bit like building a different EPR system in the middle of it all. God forbid. So we've got 4 options, I think, is where we've settled on. We keep developing the as-is, HIE++. We consolidate all our HIEs, one doing bigger areas. move towards a data-driven approach, we have some sort of hybrid. And I think our options will be in 3 or 4 at some point. We're deep in conversation about this with our London communities, because this will take some investment going forward. But I want you to think about this. So there I am. I've got it may have been a pale jumper at some point in the front with a V-neck, but it looks like I've got it dirty. And we're at a place called Jodrell Bank. I don't know if you've heard of Jodrell Bank in Macclesfield, Cheshire, outside of Manchester, South Manchester. So the story of Jodrell Bank, of course, is that in between the 2 world wars, when researchers were trying to detect aeroplanes using radar, and during the Second World War, this was accelerated massively, radar, there were spurious signals that came out from outside the Earth, and so they wanted to investigate these space electrical signals. And so Bernard Lovell went to the Public Accounts Committee and got money. He got universities to put money in. This new technology to build this radio telescope, the biggest in the world at the time, new steels, new bearings, new electronics. It was struggling, like all grand public projects. It was struggling. As it was being completed, there was a set of public hearings, and if you read the book, you'll get more detail of this, saying, well, we should stop funding this because, it's not going to go anywhere. Just swallowing up money. The Russians sent up Sputnik, the only place in the world outside of Russia that knew what was happening was Jodrell Bank, because they could track the carrier rocket. So what's your Sputnik use case? So that's why I've emphasized that going through. What's the problem you're trying to solve? How can you make it pervasive enough to move some of the problems out of the way? And that's what it did. It got funded, got completed, and became the world beater that it then was, and is still doing great research in combination with other radio telescopes across the world. So what's your Sputnik moment? For us, it was probably the pandemic. But wars, financial shocks have sort of eroded that somewhat. But I go back to this demand in our healthcare. The problem that me and my children bring us, the baby boomers. We've got to solve that problem for future generations. So that, I think, is our Sputnik problem. So we have a vision, but our vision is about health and well-being and prosperity, using the power of data at scale to make London the world's healthiest global city. It doesn't really talk about digital stuff much in that. And it's about growing it from local. Top down in this sort of space does not work well. So here's a graph. So this is from a great colleague of mine called Seb Nye. He works with me in London. And he said, I've drawn this graph. This is, in our emergency departments, we have a measure of how quickly people are discharged. What's the percentage discharged within 4 hours? And it's a sort of national measure. And a few years ago, we were up at 95%. It has deteriorated. And this is tracking the 7 regions of England over time. And apart from that green jump down, you can see that's the pandemic effect in London. London had an early and extreme pandemic effect compared to other regions. All of those charts across the 7 regions track pretty much within a few percentage points. So all the national policy, all the national papers, all the ministers standing up and saying, we're going to do this, didn't do much. So we've got to give the tools for people, because innovation happens locally, right? We've got to give the tools to people locally. We've got to give the data and the techniques and the ability and the support and the resources to people locally. And then they will help us solve these. Some will fail, but we've got to be brave in making leadership choices. And I like these quotes from Peter Senge, and forgive me, I'm going to read these very quickly. This is from 1985, and he's from the sort of dynamics group at the Sloan School of Management in Boston. In complex systems, now by complex systems he means people, across broad sort of environmental contexts. Obvious solutions often fail to produce intended results. In fact, they often exacerbate the very problems they are intended to resolve, and we've all been witness to that. We think, well, there's an obvious problem. I'll just plug A into B and it'll work. Oh, it's not worked. Good grief. In complex systems, cause and effect are generally not closely related in time and space. As managers, we expect that they are. So our assumption is we'll put a policy in place, we'll put some money in place, put some action in place, and for winter it'll be sorted, and it's not. Complex systems, remember it's people, tend to resist attempts to change their behaviour. The most common cause of policy resistance, and I love this phrase, is multiple compensating feedback relationships that attempt to maintain internal balance despite external interventions. Now, you know, I have to put my hand up in my career and say, I have often been given or awarded projects to do and not quite delivered them in the way that was expected because maybe it wasn't in our best interests locally to do it that way. I really ask all of you to put your hands on your heart and say, have you done that? Collaboration's hard. Collaboration can be measured by what you stop doing for the greater good. The last two are really important because they then resonate with the learning health system. Effective policy design requires understanding an organisation and its environment. That's why it's so interesting to hear the policy stuff earlier today. As a unified system to shift management attention away from large numbers of low leverage policies to relatively few high leverage policies. So if you set a direction of travel and allow some local flexibility, you're much more likely to have success in the medium term. Such understanding requires an ongoing management education process. The objective of this education is to shift the style of thinking within an organisation. In an organisation intent upon realising its creative potential, fostering systems thinking is a chief function of leadership. So if you're all leaders, what are you doing to foster systems thinking? And it's a really important question. And it's about collaboration and working together, allowing things to fail and learning quickly and moving on. It's about not using performance management aggressively. And I like these three pictures. So I took this picture, if that's a no, I took it on the 23rd of February 2016. For those of you know that you're south of England geography, it was taken from the Isle of Sheppey. It's a place called the Hearty Ferry. There's a pub and you can stay there in the pub overnight. We stayed overnight. It was my birthday. And there's a nature reserve nearby. And these Canada geese, resonates nicely with today as well, doesn't it? We're flying up and down the Swale River, and the other side of that was Faversham, for those of you that know the territory. But the geese swap their lead around. It's hard work getting through that air. It's hard work being a leader. So they let them rest and move around. And if you're watching them for a couple of hours, as we were, you know, there was some beer or wine and, you know, a meal, you know, that all helped. So it's just a great metaphor. We don't all have to be in charge all the time. We can look after each other. Really important, because if we don't, that can happen. Okay, and I took that on Whitstable Beach early one morning, a couple of years later, these starlings I disturbed in the bushes. And it's a sort of Hitchcockian sort of photograph, isn't it? Now, for those of you who remember Hancock in England, I first used this about summer 2020, and he wasn't in the audience. I'm grateful for that, because I did say Hancock, you know, it was such, I did say Hancockian nightmare, so, yeah, at the time. Where we're trying to get to is this. Now, I think this is AI, right? So I knew I'd get it in at the end, a bit of AI. You're most welcome to try and reverse search this and see if it's a real picture. I did take the other two. I didn't take this one. That's the honest truth. Because this is thousands, because what we're doing and what you're doing, it's thousands and thousands of individuals, policymakers, funders, industry, clinicians, digital data people, all working together with a common sort of set of aims, loosely or strongly connected, depending where they work together, all working for each other and for the public to try and have a common. So I think this is a great vision for where we're trying to get to. It's not perfect, and none of what we do is perfect, but we can move this forward. Thank you very much. I'm very happy. I love questions, right? I love you to be sort of noisy and ratty with me and angry, so go for it. We'll take questions. Have we got time?
Yeah, I think we can have...
Well, I'm stopping people from beer or something, or wine. I can't, the lights are a bit bright, I can't see who might be there.
Thanks very much. Very inspirational and aspirational presentation, so really appreciate you bringing the story over from London. I'm Karen Hay from Salesforce. Can you tell us a bit about how you, or what the approach was to incent participation and adoption at the practice and provider level? What carrots and sticks did you employ?
Yeah, so we've not paid anyone, right? Just let me be clear. What we've said is we want to make your life as a clinician a bit easier. What would you like to see? Come and get involved. We've paid people to spend some of their time working in the project, but we've not incentivized them. And then we've relied on them to spread the word. So, you know, as you might expect, I go into GP practice in hospitals quite a lot across London, and 18 months into this project, so I'd say 22, on a Sunday afternoon, I was at home with my family, I got a text from a GP said, something that takes me 5 weeks, I've done in 2 hours. So they would normally do their risk assessments on elderly people who are, you know, social care, and they would have to write off for letters. We linked up 2 social care services. They were able to see it. They were able to do their, so they made better decisions more quickly, patients better care. We publicise that, and we use that with their peers. We get them to publicise it. You know, it's not, this isn't about me, it's about how the service can improve for the service and for patients. We do employ good communications and PR people in this programme. And you know, if you go to the website, you'll see it's great, and we have great materials there. We invest in evaluation. If evaluation says we're doing something wrong, well, we'll stop it and we'll change it.